Good morning. This is Dr. Rutledge, and I'm doing a little video here in India while I'm visiting with Dr. Kular. We're working on a website that would provide a skeleton of the guidelines for performing MGB. And we've gone through the technical details, the preoperative and postoperative management, things like that. But in addition, this morning there was a comment on one of the Facebook pages about a patient who suffered a weight regain following Roux-en-Y gastric bypass. And there were a variety of very insightful and thoughtful comments, as you might predict. One of the things that was interesting, though, there were some comments that said basically this is a failure, not of the surgery, but really of the patient, not following our instructions. And I wanted to comment a little about that, and then maybe roughly compare kind of my own biased assessment of the slight differences maybe that are present between the sleeve, the band, and the Roux-en-Y, and their restrictive components and the restriction in the MGB, and suggest that when we talk to our patients, we say weight regain is not the fault of the patient. We take the blame and say it's the fault of the operation. And so I think we heard some comments here that it might be worthwhile to talk about this, and I didn't type up the whole thing because I could imagine that most people would get quite tired of reading an entire treatise on this topic, but it might be worthwhile to watch a quick video. So let's go back and say there is an idea that has come out, and it's called blaming the victim. Blaming the victim. And it's kind of the opposite of the old Calvinist idea, which said that if you are successful and work hard, that is an evidence that God has blessed you, that you are a chosen one of God, that if you're successful, it really means that God has picked you out and given you those blessings. And the converse of that can be taken quite negatively, and I don't think it's always intended. But the other thing is, if bad things happen to you, you're a bad person. And so the example of this blaming the victim came out in, say, for example, people in poverty. Well, they're in poverty because they don't work hard. They don't have good character, things like that. And in this example, we use this term, and it may be a little harsh, is when bariatric surgeons blame the patient for the failure of their operation. In other words, many lap band surgeons, sleeve surgeons, Roux-en-Y surgeons I have heard very honestly say, gee, look, obesity is really a terrible problem. We've given the patient a tool, and if they fail, really that's their fault. It's on them. Because we've given them one of the best operations that is available at this time. And if there's a failure, really it's a failure of the patient. We've told them to eat better. We told them to exercise. And when they come back and we find that they're eating junk food, they're not exercising, they're regaining their weight, we say, well, that's their fault. We did what we could. And just as an aside, one of my patients is a medical student in Canada, and she served in a lap band clinic, and she noted to me, that the clinic was filled with lap band failures at that time. And she noted that the surgeon did not feel bad about this at all. The surgeon, a good, honorable person, just said, gee, these people were given an excellent tool with the lap band, and they failed because it's their character. It's their lack of willpower, things like that. So I'd like to argue for a second that I don't really agree with this approach. And when we talk to our patients, we say, look, we think the MGB is good. We don't think it's a character issue. We think if you have a good, effective operation, it will take care of the problem. And so as an example, we don't blame people if there's a failure of a cholecystectomy and other things. And this brings in the whole idea, is there a psychiatric component? And I think I won't go off into that too much except to say I don't think it's a psychiatric issue. And I don't think psychiatric interventions help very much. And now I can immediately see that I'll get a couple of emails on that topic. But let's go a little further then. Let's say that you want to take the hypothesis that a failure of a weight loss surgery is actually a failure of the weight loss surgery and not of the patient. And then you come up with, we have pretty good, I think, growing agreement that the lap band has a limited effectiveness, and it seems to be dropping in popularity because it fails a lot. And my bias is that's not a failure of those patients. We see the sleeve, and in my analysis here with some sleeve patients performed by Dr. Kular, we see excellent results in the short term, but a progressive failure as time goes by. So what we argue is that there may be something inherent in this particular Roux-en-Y patient, the sleeve patient, and the band patients, and the vertical banded gastroplasty patients before them that leads to a progressive failure. And maybe we would argue there's a difference with the MGB. And so let's talk about the restriction. Now, I don't have all the data on the exact amount of restriction for Roux-en-Y, sleeve, and band, but significant restriction occurs, and that's obvious. The total amount of intake decreases, and that's because of restriction that's primarily, we would call it obstructive. In other words, there's a tight, narrow area, and the analogous experience in general surgery is an esophageal stricture or esophageal cancer. Those patients lose weight and get thin, and that is understandable. They've got a stricture, and essentially a lap band is a fixed stricture. The sleeve, in my opinion, is roughly a primarily obstructive component, a long narrowed portion of the GI tract that's narrowed with a near obstructive outlet in the pylorus. And the Roux-en-Y, because Roux-en-Y, of course, we focus on, we hear the experts in Roux-en-Y say small pouch and small gastrojejunectomy. The MGB, though, is odd in that it has about a 75% decrease in caloric intake post-op in my studies, and intriguingly, it has a very large pouch and a very large gastrojejunectomy. And early on, many of my colleagues, and I still can point to them and give you the names, said, oh, the MGB will cause no weight loss. It will cause no weight loss because your pouch is too big. You're doing a gastrojejunectomy, you're doing a bypass like a Roux-en-Y, big gastrojejunectomy, big pouch. Yet, the weight loss is excellent after MGB, and in controlled prospective trials, it's at least as good or better than long-term Roux-en-Y comparisons, and maybe better, and there are techniques to make it more powerful or less powerful. But why? Why? Because the restriction is there, but it's non-obstructive, we say. And again, we think because it doesn't rely on a stricture that can change over time, there's less likelihood of regain, because what we think happens in a strictured type physiology is that patients with good honorable intentions try to eat healthy food like broccoli and they vomit. They try to eat an apple and they vomit. They try to eat a sandwich and they vomit. And so the experience that many surgeons have is obviously those patients migrate to soft calories, to liquid calories. And the Coca-Cola, for example, thousands of calories a day can be obtained in a negative way by just drinking your calories. And oftentimes we argue that that's actually induced by the stricture type or the obstructive type physiology that's present in the Roux-en-Y, the band and the sleeve and the old vertical banded gastroplasty. And all of those, I think, tend to fail over time with varying rates. The MGB, of course, though, is non-obstructive. In India, we judge it by chapatis, which are the flour tortillas that are eaten with dinner. And most pre-op MGB patients here in India eat about 4 chapatis with dinner, and post-op they eat 2. And if they have a sleeve, they try and eat 1 and usually vomit and throw up. So I think there is a potential to understand this better by looking at this different approach. In addition, we do see some failures late in MGB, and one of the other advantages is very easy to revise those patients, and I'd be happy to talk about that on another video. So a brief answer, I don't know if it helps at all in this particular case, but I thought I would provide this video for those who are interested. Thanks very much.